So, welcome everyone to another of More Tomorrow's Live, Learn, Inspire, and Value for Liver Health series that's hosted by the Fatty Liver Foundation, soon to be the Steatotic Liver Foundation. We're undergoing the name change, and also Sober Livers, which is part of our organization. Today's webinar is Bridging the Gap in Care, the inclusion of alcohol-related liver disease and metabolic dysfunction and alcohol-related liver disease in steatotic liver disease. So ALD, MetALD, and SLD. We'll be using the abbreviations from here forward. My name is Dr. Niraj Mistry. I'm the Chief Medical Officer at the Fatty Liver Foundation, and we're delighted always to have this program supported by a grant from Madrigal Pharmaceuticals. Next slide, please. So as you know, our disclosure and disclaimer statements, this is for informational and educational purposes. We'll be discussing a lot of research. We are not making direct recommendations or prescriptions on what your management should be, but certainly take this information to your care providers, your multidisciplinary teams, and this gives you more information to discuss with them. Next slide, please. Okay, so this is a slide I've been using over the past 3 or 4 years, and this is about the perfect storm, the confluence of all these metabolic and chronic comorbidities that descend on the liver. For a long time, we haven't had any treatment for it. It's been the leading cause of liver transplant. We often talk about an ounce of prevention is worth a pound of cure, and certainly inaction in the early stages of disease results in much higher costs related to liver transplantation, etc. And the biopsychosocial approach, so important in managing holistic care of our patients with lifestyle, behavior change, diet, etc. And now more so when we're dealing with addiction-related disease. Next slide, please. But it isn't a perfect storm anymore because we've seen in the past 5 years tremendous amount of new developments, technologies, etc. Multidisciplinary teams in many parts are becoming the mainstay in managing complex conditions like this. We have resmetirom, we have semaglutide that are being used for various stages of fibrosis. We have better comorbidity risk management, non-invasive tests, renewed focus on lifestyle and behavior through the inclusion of alcohol use disorder, a much more organized patient community, and certainly the new nomenclature has breathed new levels of awareness and invigoration in this response that we've been dealing with. But we certainly have ongoing risks that we need to address. Next slide, please. Part of which is the level of undiagnosed disease that we're dealing with MASH and MASLD, or the broader steatotic liver disease. And part of that is ALD and MetALD as well. So we feel we've only touched the tip of the iceberg, and there's so much deeper to go into with that. Next slide, please. So for today's webinar, we have a powerful 1-2 punch with our two experts on the call. And so I'm going to briefly give you their bios. We have Dr. Jessica Mellinger, who's an internationally respected hepatologist, transplant physician, and clinical scientist whose work has transformed our understanding of ALD and the integration of addiction medicine into hepatology care. Dr. Mellinger is a faculty member at Henry Ford Health in Detroit and serves as an associate professor of medicine at Michigan State University. Her research focuses on alcohol-related liver disease, alcohol use disorder, liver transplantation, implementation science, and improving access to evidence-based care for patients with chronic liver disease. And then we also have Dr. Juan Pablo Arab, who's one of the world's leading physician scientists in ALD and MetALD. Dr. Arab is a transplant hepatologist, associate professor of medicine at Western University in Canada, and a scientist at the Lawson Health Research Institute. His research spans ALD, MASLD, MetALD, liver fibrosis, cirrhosis, transplantation, and global liver disease epidemiology. So we couldn't have asked for a better team of experts to help us walk through this issue, especially with the change in nomenclature. So welcome the both of you, and it's a pleasure to have you here with us. Thanks for being here.
Thank
Thanks
you.
for
Thank
inviting
you.
us.
Excellent. And I think we always start off with a check-in. How are the two of you doing? Quite busy schedules, clinical schedules, self-care. You prioritizing that as well?
Trying. I'm trying to get better at
Yeah,
exercise. So that's my new thing for self-care is trying to do that more, but we'll see how that goes.
Excellent.
yeah.
Dr. Roth?
I'm actually visiting family now. I'm in Chile now,
Oh,
so
cool.
that's why long flight, but I made it. So uh, glad to be here.
Oh, excellent. That
Nice.
makes your presence even more special. Just anecdotally, one of my favorite phrases as a physician is Doctor, heal thyself. And so much of what we deal with, rates of alcohol use in the medical community is so high. So we have to sort of take our own medicine quite often.
Mhm.
So both of you have been closely involved in advancing our understanding of alcohol-related liver disease. Why is it so important now that we move away from thinking about ALD and MASLD as completely separate diseases? So, Jessica, do you want to start and
Sure.
then we'll go to Juan
Sure.
Pablo? Yeah.
Yeah. Well, I think what we've seen kind of certainly over the course of the past decade or so in my own career is this growing recognition of the field of hepatology and especially with MASLD and with ALD really being driven a lot of times by behavior, right? Like what we're doing as, individuals and some of these behavioral aspects. And there's a lot of overlap. So I think we're seeing more and more that, a lot of our patients uh, may drink, but also have diabetes or also, struggle with their weight or carry excess weight maybe around their midsection where it's more cardiometabolically active. And so when we have these two things together, there's been a greater, just a growth in the understanding that these things are synergistic, they act together to worsen liver disease and that they change over time, right? So it's not a static problem where you drink the exact same amount your entire life or you have the exact same metabolic, symptoms or diseases your entire life. They kind of fluctuate and they can move and change throughout people's lives. And so I think there's just been this growth of a recognition that, we can't really fully pull these things apart and that they're really contributing to liver damage, often in a very pathophysiologically similar way, too.
Um, uh,
Yeah,
that's that's such a nice way to put it. Juan Pablo, you want to
yeah.
add?
I, just a couple of numbers. I'm a numbers person. So if you consider all liver disease in the world, and you take what are the two main risk factors, and you get rid of those two main risk factors, which is number one alcohol, number one is obesity, you can get rid of 85% of liver disease, 85.
Mhm.
So, and that tells you how important is steatotic liver disease from an alcohol perspective and also from a metabolic syndrome, obesity perspective. If you consider in the past, we kind of try to keep things divided, separated. One was alcohol, and then the other one was the old fatty liver. When in reality, that's very difficult because, only in the US, 67% of the current population uh, drink alcohol currently or recently. So how you divide? And then we have, 70% of the population in the US does not have a normal weight. It's either overweight or obese. So when you have two things that are in 70% of the population, if you are aiming to have only people that has only alcohol and nothing else, or only metabolic syndrome and nothing else, you are going to minorities because the vast majority is in this mix of one or the other. Of course, for different people, there is one that is going to be the predominant, right? And that is probably the one that is going to be driving the disease process, but doesn't mean that this thing happened in isolation. And more than that, because I think these are more kind of philosophical discussion. I think from a practical perspective, I think understanding steatotic liver disease as a spectrum, what is allowing is both patient and physicians to recognize that both things can act together, both things should can be present, and we should be asking and probably intervening in both things. Both things has to be with behaviors and has to be with um, uh, things that are making your liver to develop more fibrosis. So we need to address both, even if you are in the what pure alcohol side, you still can have some metabolic risk factors, and you can still have cardiovascular events. So we need to address those things.
So this actually sets the stage really nicely, because what the two of you have talked about is this complexity of these diseases, and this complexity interacts. And I think in addition to the complexity of etiology, risk, comorbidities that tend to exacerbate each other, we also have a timeline. And I like the way you described it as a spectrum. And so while we have these two big broad categories of alcohol-related disease as well as metabolic related associated disease, under them are an entire milieu of risk factors and diseases that we're dealing with. So I think that adds a lot to the complexity of it. Now, in particular, MetALD was possibly the most significant addition to this broad SLD framework that we talk about. What was the clinical problem that MetALD and the inclusion of that in the nomenclature was designed to solve?
Maybe I can go first this time.
Yeah,
Go for it.
please.
So I think it was the overlap. As I was mentioning, if we consider only ALD or only MASLD, probably we were missing this population in between that has high alcohol consumption, but also had very high cardiovascular risk factors, and and we were not thinking that this thing can coexist. I mean, we knew it in clinical practice, but
Right,
when you were in front of a patient, you had only two options. The patient was ALD or NAFLD, was nothing in between.
right.
So I think MetALD came really to give awareness that, oh, these two conditions can coexist. And probably the patient may be having um, damage and may be having progression of the liver disease because of both. And then you need to assess both, you need to diagnose both, and you need to treat both. Um, so I think that's really the biggest step forward of the new nomenclature in saying, hey, these two conditions may coexist, and MetALD is the name that it came to recognize. Okay, this is an entity that it sits in between, and we don't know very well how it interacts, and this was basically an agreement, a consensus of saying this thing exists, but we didn't have much data at that time to say, well, this is what happened with this entity. It's a completely new entity.
So, Dr. Rab, I want to ask a bit deeper on the epidemiology, because when we were at the past two liver conferences, on all panels, when they was talking about the new nomenclature, um, a lot of the hepatologists on the panel said, I can't quite believe the data around the numbers and burden of disease related to that. Was it purely because we weren't classifying patients? And now that we have the new nomenclature, are we classifying them and seeing a spike in the prevalence?
So that's actually a good question. I agree. I think, how the definition came was basically trying to um, incorporate all the patients in the old NAFLD under the MASLD, and then recognizing this spectrum. But the cutoff are completely arbitrary, right? Because there is no great data there. And actually, the data that is used for alcohol for ALD is all data that show how much you need to drink over a period of 5 years or so to develop
Mhm.
cirrhosis. So it's not talking about steatosis, right? It's talking about the end of the spectrum. So the
Right.
cutoff are very high, MetALD sits kind of in between, but with no data. It basically it caught between what we call, ALD, which is basically ALD cirrhosis, and then MASLD. And the definition of MASLD is 20 and 30 grams per day for men and women. Came from a pathologist definition of what was considered. If you consider what the NAAA consider heavy drinking, it actually sits within MASLD.
Mm.
So, all this cutoff is not dogma, it's not absolute truth. I think these things are going to change over time when we have more data. But we needed to start somewhere. We didn't
Right.
have a strong data. So I think it's more the intention of saying, okay, this is what we have. The other big problem is we only consider current alcohol consumption. So Jessica was saying, what do you do with patients that were very heavy drinkers for 20 years and now
Right.
are drinking 1 beer per day? Is that muscle-D? I don't think so, right? But we needed to start somewhere, and with all the caveats that this may have and the limitations, I think that is what it came. The problem with epidemiology is you ended up, if you look like enhanced data, so National Health Survey, and 32% has muscle D, then like 3, 4%, between 2 and 4 has MetALD, and 1% of the population in the US, adult population, has ALD. So these numbers are not true, probably are completely biased. If you consider how many adults in the US, and this is data from NAAA, has an alcohol use disorder, is 10%. So it's 8 to 9% in females, and it's 13% in males, adult population in the US. So how you go from 10% with AUD to 1% with ALD? I mean, ALD cirrhosis maybe, but ALD, if you consider steatosis, it needs to be at least 10%, at least. Um, so um, again, none of these numbers are absolutely true. And probably the true measure, we don't know because there is no studies, but it gives you an idea. And then on the other hand, so if you say muscle D with the D at the end, so disease, can you say that 32% of the population in the US has a disease? I don't know, maybe it's a condition or something, but to
Right.
tell someone has a disease, 32% of the population, I don't know.
And maybe it's a catch-all for people being on a spectrum or that progression. But the operative word you used is bias. And I think that's for a whole other webinar and a much deeper, possibly politically charged conversation. So we'll put that in the parking lot. But my hope is that now with the catch-all nomenclature, we will start getting more accurate reflection and redistribution of the burden of disease across the classification. And then hopefully we would be able to program better for that. But Dr. Mellinger, you've been at the coalface dealing with patients in the clinical context. And the inclusion of MetALD, has that changed the way you particularly practice and the field of hepatology has been practicing? And one of the adages that we had at medical school was the patient doesn't read the textbook. So we have our
Right.
not neat classifications, etc., but presentation is very different. And part of the challenge we had is we became super specialized in medicine, and now we have to look at a more general sense, particularly with hepatology and SLD.
Yeah, absolutely. I mean, I think you're spot on in the sense of that some of this discussion is kind of academic about these different cutoffs and what we're calling things and new names. We all get excited, because there's something new to put, write papers about and write grants about. And I think the clinical significance, I think, is there, but as JP said, it's yet to be fully defined exactly what is the clinical significance of this overlap. Clinically, I mean, again, and I see, mostly advanced ALD patients. So in our integrated clinic, we tend to see patients kind of on the more advanced end of the ALD spectrum. So my practice tends to be very different than, say, a general GI doctor or primary care doctor who is seeing more of these early stage steatosis only, or just steatohepatitis, no cirrhosis type patients. And so MetALD as a diagnosis hasn't really impacted how I practice because for me, when I'm looking at my patients, the issue is still the same. I need to help them stop drinking. I need to help them, get connected to alcohol treatment to stop drinking if they can't stop on their own. And as JP said, yeah, address the cardiovascular, risk factors as well, which is often being done, by my primary care colleagues. And maybe I'm giving advice on which anti-cholesterol agent is safe to use in advanced liver disease or et cetera. Like, yeah, they actually don't need their antihypertensives anymore because advanced liver disease drops your blood pressure, so they can come off of some of these things. And those are kind of the ways that it is impacting. I mean, certainly with the rise of the GLP-1s, I've had more and more people, who have this conglomeration of issues. They're heavy drinkers, but they also have obesity and they have diabetes. And they have an interest in the GLP-1s because of their because of wanting to lose weight and so forth. And now there's some emerging data in human data and randomized trials that shows that these may help with craving and alcohol reduction as well. So I think that's also an area where, with this combo of metabolic syndrome and metabolic conditions and alcohol use, whether you call it MetALD or not, or where we make the cutoff, again, clinically, what I'm doing is trying to select things that will help my patient get better, reduce, stop alcohol, help fix reduce the body weight, help with the diabetes. And so anywhere I can do a 2-for-1 or a 3-for-1, I try to do that. If there's a medication that will help, my patient with weight loss and alcohol use, great, let's look at that. I always tell my patients exercise. There's data that it actually helps with alcohol reduction in addition to the direct benefits on liver health that exercise can bring, in a structured, safe way, working with a physical therapist and someone who's giving folks safe exercises to do when they have liver disease. But there's a lot of that. There's a lot of these things. So I think that's sort of how the MetALD has sort of changed what I do is I really am looking for, where can I give my patient, a medication or a behavioral intervention that's going to give them, more bang for their buck, right? Going to give them benefits in multiple ways with multiple things that they care about too, right? I think that's also really important that, my patients have, often want to stop drinking. Sometimes they don't. Sometimes there's reasons why they don't or feel like they can't, or maybe they want to be a little more focused on their weight loss, et cetera. And so we kind of work with them to tailor the approach around what they think will work in their life and what they're willing to do.
So, um, so I love it. I think you're going to get a lot of patients calling up your practice and saying, "Please come see you." But do you think the approach that you're taking, and because I think a lot of it is related to the fact that this alcohol-related disease was your practice area,
Right.
so you had to
Hmm.
look at the patient in a much more holistic way. Do
Hmm.
you think that this is a norm or is a trend with all hepatologists or most hepatologists with GI docs, etc., that are in sort of the primary carers for a lot of our patient community?
I do think there is a trend towards more recognition of this. I mean, I'm very aware, I think JP as well, that we practice, we're very fortunate that, JP and I both have integrated ALD clinics where we have, mental health addiction professionals sort of at our side seeing patients with us, and that's great. And I love that. I'm very glad that we have that. I think it's good for our patients. But that kind of care integration and that focus on, kind of the interaction of these different things together can happen at many different levels. And it is happening at many different levels. A lot of folks who refer to me, they're trying some of these relapse prevention medications with their patients first, or they are prescribing the GLP-1s because they also have seen the data on alcohol reduction and have had that conversation. And so maybe they come to me on a GLP-1 or they come to me already on this. I've seen that growth a lot, over the course of the past decade plus that I've been in, the ALD field and working in it. I've definitely seen across the board in hepatology a greater recognition of, oh, I actually can start some of these medications and I can do some of this, you know, behavioral counseling, brief intervention, type stuff, getting folks referred to, alcohol treatment. So, well, I think we definitely have seen a growth in integrated clinics popping up all over the country. I did a search recently just to see, because I think our University of Michigan one about 9 years ago, 10 years ago, was the first one in the US that I was aware of. But there's like 15 or 20 now, I think. I was trying to think of all the ones that I knew, and then I know there's ones
Right.
that I probably haven't heard about. And I was like making a little map out of them. And I think there's probably about, close to 20 of these around the country now where people are really recognizing it. So I definitely think it's not just a trend, it's here to stay. It's a recognition of the fact that, just like we turned into virologists for hepatitis C and we treated hepatitis C and we're immunologists for autoimmune disorders that cause liver disease, like the same thing, we need to be comfortable treating addiction and comfortable recognizing it and diagnosing it and helping people with these issues. And that has really grown a lot, which I'm really, really grateful for.
We were actually really pleasantly surprised with the number of MDTs that are arising, or these multidisciplinary centers that have been arising. And at the same time, we've also still see what we call hepatology deserts.
Yeah. Hmm.
And so linkage to care is something that preoccupies us a lot from the patient community. And so I want to go to the patient perspective, and I think from a medical point of view, or a scientific point of view, we have an indicator, we have a metric, and we're happy with that. But the soft issues are the hard issues to deal with, right? And particularly stigma. And part of the nomenclature shift was to actually deal with stigma. And so, have patients respond differently now that we have this new terminology with SLD? We don't talk about alcoholic anymore. We talk about alcohol related, etc. So, what's the reaction been like with the patient community? And are we achieving that goal in starting to destigmatize all of this?
Hmm. Do you want me to take that,
Uh,
JP?
JP, do you want to start? And
Yeah,
then we'll
go
go
ahead,
to
JP, and start.
Dr.
Yeah.
Lisa.
Sure. No, I think that's actually a very important step forward. It was from one side was the alcoholic, and then it was the fatty. During the discussion, it actually, I mean, I never thought before, but it was a pediatric hepatologist, and she said, "How I tell a 12 years old you have non-alcoholic fatty liver disease, right? Kind of doesn't make sense in the pediatric population.
Right.
Jessica and I both only see adults, so I think I never saw it before, but yeah, I think the NAFLD has to change, and in part has to be with the stigma, and it has to be with how in the liver disease field we have been very centered in etiology, and we have been very centered in alcohol, like in but not in a good way. I think from a stigma perspective. Um, I mean, for example, I always use as a parallel like lung cancer, right? I mean, you smoke, and there is very well known um, um, relationship between smoking and lung cancer, but we don't call it like a smoking or non-smoking lung cancer, right?
Hmm.
Is why you need to use the etiology to describe a process.
Hmm.
I think in the liver disease field is because the liver respond in an stereotype way, and you're going to get fibrosis and cirrhosis for many reasons. But still, I think the putting everything under the umbrella, it helps in both ways. It helps to reduce the stigma, but also helps with recognizing and more awareness. I remember before the nomenclature, it
Mhm.
was almost automatically the patient had an ultrasound with fat in the liver and is NAFLD. Like is almost
Hmm.
automatically. And
Mhm.
either no one asked about alcohol, many cases,
Hmm.
nobody asked the patient if the patient was drinking. Or number two, they asked in the wrong way. So there is two wrong ways to do it. One is you don't drink, right? Of course, the
Oh,
patient is going to say no because
the leading question. Yeah.
you are inducing what is the answer. And then the other one was the like, oh, you drink, and then how much occasionally or socially. But then nobody was digging deeper. The problem is socially, the patient may consider that socially is drinking a case of beer, right, per day. Because what is socially or what is occasionally? So I think one of the big step forwards of the nomenclature was, okay, let's talk about this. Let's reduce the stigma, but also let's try
Hmm.
to get real data, not only, very soft talking about this thing without going deeper. I think it helped to recognize we need to talk, we need to go deeper, and we need to talk
Hmm.
without stigma. I mean, when a
Hmm.
problem is 10% of the adult population in the US, it's something that we need to do something, and we need to deal in a way that people is struggling with this. Nobody wants to
Hmm.
struggle with this. And now how we can
Hmm.
help them.
Yeah, I think that's really, I think those are really great points, JP. I think one thing I would say is that what I appreciate about the change to metabolic liver disease is that it's more scientifically accurate, right? It tells you what is causing this thing, this
Right.
condition in the liver, and not what's not, right? So it was always really confusing when I would recognize that my patients had metabolic complications and had NAFLD, but also drank. So I had to tell them, well, you have alcohol-related liver disease, but you also have non-alcohol-related liver disease. Like that just
Yeah.
didn't make any sense, right? So I
Mhm.
think the scientific accuracy of the name is really important. I do think that we need to be more specific and precise about what stigma is. So stigma is when we make a moral judgment that somebody is bad, because a bad person because they have a condition, right? Like that's what a lot of my patients encounter, right? And I started talking with them about this. Like, yeah, in our healthcare system, we often don't treat patients with alcohol use disorders well, right? They come in, maybe they're struggling with withdrawal and they have other physical symptoms, and those physical symptoms get ignored and not fully worked up because they say, oh, it's from alcohol, right?
Mm.
Or they just don't get treated nicely. They're not treated with respect, et cetera. And many of them are told, in various ways, directly and indirectly throughout their lives that they are bad people because they have this problem, because they have this alcohol problem. And so many of them internalize that and they come in, saying, oh, I drank again. I just feel so bad about myself. I feel awful that I did this. I feel, I didn't even want to come. I didn't want to tell you, because there's all of this shame and stigma. But what stigma is not is it's not just feeling bad because of something, right? Like we can have a disease process and not like that we have that disease process, right? That's not stigma, right? That's not stigma. Stigma is not, my therapist has asked me uncomfortable questions and I'm not sure I want to answer them. That's not stigma,
Mhm.
right?
Mhm.
My doctor is bringing up a topic that I maybe don't want to talk about, like that I've gained weight or that my PEth levels were high. And it makes me uncomfortable to talk about it and I don't want to talk about it. That's not stigma. And so I think we have to be very careful that we separate the judgment, the moral judgment that is inherent in the term stigma from these other things like discomfort. I don't want to have this. I wish I were normal, like all of these other things. I have patients in Alcoholics Anonymous who call themselves an alcoholic and they take great pride in that. They do not find that to be a stigmatizing term at all. And so we use that term when I'm in clinic with them. So I just think, yeah, it's great that we changed the terminology to be more accurate, but I think what we often do is then we stop, right? We're like, woohoo, we changed the term, we're done.
Mm.
We don't have
Right.
to do anything else, right? I mean, I think Wei Yang at Wei Zhang at Harvard is doing some really interesting novel work in developing a way of measuring stigma in ALD patients because we need to measure it and identify it so that we can then do things to actually reduce stigma itself and not kind of, conglomerate it all together into this thing and then say, well, we changed it to steatotic, guys. What more do you want? Like that's
Mm.
Right.
that's probably not, I mean, I hate to say it, that's actually not going to reduce the stigma my patients feel. I really don't
Yeah.
think it is. I think it makes us feel better and it's more accurate, but I actually don't think it's going to do much for the cultural societal stigma. I think that's going to require a different way of talking about this, a different way of presenting it. What I say to my patients is your alcohol use disorder, and I tell them I use the term alcohol use disorder. That's our technical term, right? But it's a medical problem, right? It's a
Mm.
medical problem. Most of the patients I see have alcohol use disorders, addiction, right? Not everybody who drinks heavily does, right? That's a diagnosis that you make
Right.
on the basis of these, the criteria. So I tell my patients, like, yeah, this is a medical condition. It is a brain issue. We know this. And I wouldn't just ask an Alzheimer's patient to just remember better, right? I wouldn't do that. And so similarly, when I talk with my patients about this, it's like my job is to help you like get treated, right? It's not your job to automatically trust me when you come in. It's my job to earn that trust and then to help you with this, and help you find the right treatment so that you can maintain abstinence. I think that like if we change how we talk about it, hopefully we can reframe for folks what this really is. And also, I think critically, reframing for our colleagues in the healthcare system, right? You know,
Right.
that's really, I think, the key, not just our patients' self-stigma, which is so important, but also reframing in the healthcare system.
Um, Absolutely. So there's so much there, and our panel, our participants are loving what you're saying, and this is going to be recorded, so we'll definitely spread it far and wide. I just want to add to the attendees, please feel free to put in questions on the chat or the
Mhm.
Q&A, and our experts will get to that while the other is speaking. So, a couple of things. One, I think when we came up with this big terminology under which there's so much, so we then realized it's not single factor causation, it's multiple causation, right? And then by not singling out a particular behavior, a particular lifestyle, a particular habit, we are sort of reducing stigma by not saying it's one thing, right? So it's not
Mhm.
a single point of failure or moral failure in that sort of sense. But at the same time, what you're talking about is also very important because very often it's our patients meeting the healthcare system instead of the health system meeting the patient where they at. And it's
Mhm.
not a generic patient. It is a wide range, a spectrum of patients. And that understanding of those risk factors, of the conditions. You have one person who has 2 drinks a day, one person 1 drink a week, and the effect could be different. So that sort of nuance, that patient individualization is so important, right? And we're getting into the realm of personalized medicine and all of that.
Mhm.
How do you manage seeing patients and being able to read each patient individually?
Yeah, I think it's a great question, and there is so many answers as so many patients, right? Because you will
Right.
need to see. I remember from the old era when all our transplants were due to hepatitis C. And again, to Jeff's point, we like to have a single thing where we do a single treatment and it's solved. And but many of those patients had, persistently elevated liver enzyme post-transplant. And then we realized that many of them had actually an alcohol use disorder that was never recognized and never treated. Um, so it's true, this exists. I think on one side, we don't want to put blame only on one condition, but on the other hand, you want to address those issues, right? Because if you leave them
Mhm.
unaddressed, then you are going to have issues down the road. So I think it's important both.
Mhm.
What is the right way? I don't know if there is one way to do it. What I usually do is be very honest, very open, very guilt free. I mean, nobody is guilty of getting sick. Nobody wants to get sick.
Mhm.
And as Jess said, alcohol use disorder is a brain condition. It's a disease. It's a disorder where you need
Mhm.
treatment, and we don't blame people for getting sick.
Mhm.
So we are there to offer help. And
Mhm.
to this point, is same. In the past, what we used to do is tell people, I mean, you have alcohol-related liver disease. You need to be abstinent 6 months, and then we are going to transplant you. So go home and be abstinent for 6 months and come back, which in reality that's not providing care, is
Mhm.
providing advice at the best. um, Caring for AUD means you need to get pharmacotherapy for AUD, you need to get behavioral therapy for AUD, peer
Mhm.
support, everything that we have, right? But I think it's not fair to ask someone to get better if you never provide the treatment.
Yeah.
Right.
So
Hmm. Yeah.
so I think all those things are in the tables. I think we need to
Hmm.
recognize this is a problem. And I think
Right.
the treatment of AUD start by saying, I think I have a problem with alcohol. But
Hmm.
then the next step is like, what do we do with that? Okay, and
Right.
so you need pharmacotherapy, behavioral therapy. Are there any other liver disease? It's the same that we do in both sides. So it's ALD and AUD. In ALD, we are going to look for hepatitis C, V, MASLD, autoimmune. And in the AUD side, well, is there any other psychiatric comorbidity? I mean,
Hmm.
alcohol use disorder very frequently goes with depression, anxiety, PTSD, chronic pain, insomnia, you name
Hmm.
it. I mean,
Right.
in our culture, we use alcohol to celebrate, we use alcohol to mourn. And
Hmm.
sometimes, many of my patients, they started heavy drinking because they couldn't sleep at night. And at the
Hmm.
beginning, alcohol was actually helping. And then it makes things worse. And then they got an
Hmm.
AUD. But so I think we need to, as a physicians, you love when you have a single thing that is very easy. But
Hmm.
reality and every patient is much more complex. And then to your point is personalized medicine. Women can drink less than men, depend on your weight, depend if you have, for example, gastric bypass. You don't have an stomach anymore.
Hmm.
There is no first metabolism in
Hmm.
the stomach. That alcohol goes directly through your portal vein back to your liver, so you can get more liver injury and more likelihood of developing liver disease with lower levels of alcohol. Also genetics. So Hispanics, there is a gene or a polymorphism called PNPL3, which is very frequent in Hispanic population and predisposed to developing more liver disease. And also there is a genetic component of the AUD. You can see that sometimes patients will tell you, well, my father, my mother, my grandparents has alcohol
Hmm.
use disorder, and they have it because there is also a genetic component. So that also reduces stigma because, I
Hmm.
mean, you are at a genetic predisposed to a high risk condition.
Absolutely. Yeah, I think, and I agree with everything JP said. I mean, I think the notion of the personalization of this is really critical, right? I probably spend in my clinic, I would say 90 to 95% of my time where I'm not managing the hepatology condition and the physical symptoms, um, talking about why people don't want to go to alcohol treatment. I mean, it is the single biggest thing I do is motivate, not motivational interviewing. I don't really generally have to convince people that they should stop drinking, right? Maybe people don't want to or they're fearful of what, but they all recognize. I mean, our patients are smart people. I mean, my patients are universally intelligent. They don't need to hear alcohol's bad for you. Like they know that, right? So
Hmm.
they're stuck on a different problem. They're stuck on a different issue of, and maybe this is an American thing. I don't know, this notion of like I can do it by myself and it's better if I do it by myself. Like I don't know why that is, but I think I encounter that like 100% of the time, right? Well, I want to do it by myself. And so get curious. I ask them why. Why if you broke your leg, would you just walk it off and say I want to heal that bone by myself because it's better, right? If you get diabetes, do you just think really hard and your pancreatic islet cells work? No. You go and you get help and you need help. And it is very true that that a lot of people actually can get natural recovery from alcohol use disorder without going to formal treatment. But I will say that's really not my patient population in my ALD clinic. These are typically people, again, advanced ALD. They've had multiple runs at trying to quit on their own. They are universally strong people. They have a high amount of willpower. But this is not a problem that they can fix with willpower, right? Like that's the issue here. And so for us in our clinic, and I have to shout out Scott Winder, who's my psychiatry colleague and sort of my partner in crime in this from like day one in the start of all of this. This is what he does a ton. Like I'm trying to get them to be more open to what Scott is doing, and he's trying to say like, well, hey, what are you into? What are you interested in? And maybe they're only interested in seeing Scott again in 2 to 3 months. Okay, great. Like we'll work with that. It's incremental change. I think to JP's point, right? Like we like the big dramatic thing that fixes the problem, right? Look at what
Right.
happens with surgery, with transplant, right? Who gets all the accolades? the surgeon, right? They're with that
Right.
patient for 12 hours and 11 and a half of it, the patient's unconscious, but they're the ones that everybody's like, oh, thank you for saving my life. That's so amazing, right? Because it was this big dramatic thing. And it is amazing and it is awesome. But the incremental change that comes about from developing the relationship, gaining trust, working with your patient, making the changes that they can do, that's really where I think the money is. And I would say too, I do not infantilize my patients. My patients are capable of taking action for their health. And I think we have to be careful too when we're talking about stigma and systems and the processes within which we live. I think that's all very true, that there are barriers and so forth. But there are things and actions that my patients can take to improve their health. And our goal is to find that and then to say, yeah, we expect this. Like if you're struggling, pick up the phone, right? Like that is not too much it isn't too much to ask to say communicate with us or with someone on your treatment team if you find you're struggling. So I think that's really critical too, to partner with the patient and not infantilize people.
Um, Absolutely. And we did have Scott on one of our
Oh yeah,
webinars previously. It
great.
was just amazing. I think it was one of the highest YouTube viewing numbers that we've had that followed up on it.
Awesome.
So, and one of the things we discussed, and I was in a conversation on mental health, and you know, we all conditioned to believe that we have to be so independent, job, money, income, tie your shoelace
Hmm.
yourself, etc. From the time we're kids all the way through adulthood, that we feel this need. It's almost a reframing we have to do from
Hmm.
moving from independence to life is about interdependence, right?
Hmm.
Someone's got
Yeah.
my back and I've got theirs, and that's how we need to live. And so this team approach is very, very important. Now, I think from the recent JAMA article, which was excellent, and we've sent that out far and wide to our community,
Hmm.
if I had to take anything from that, it's three words: early, 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 right?
Hmm.
The earlier we do things, the better. And what we picked up from our state of steatotic disease care survey was that the first port of call, diagnosis, suspicion, etc., of disease, is with the PCP. Okay.
Hmm.
And our primary care providers have on average 8 to 10 minutes per consultation, right?
Hmm.
So, what would your advice be to primary care physicians and their patient interaction? And how do we empower our patient community, given that they've got to have a high index of suspicion
Hmm.
and they've got to take the preliminary tests? What needs to happen at that primary care level?
Yeah, it's an excellent question, and I hate that I feel that every subspecialty is trying to put more work on primary care, but it's not doable. If you look like how much they are asked to do, they daily work hours, it should be like 27 hours if you do everything that PCPs are supposed to do.
Yeah.
So I will say two things. Number one, you are right. Early identification is the main issue in liver disease. So, liver disease is diagnosed late. If you consider only ALD is the one that is diagnosed even later. So, ALD in liver disease in general is a problem. In ALD is even a bigger problem. In primary care, I think you need to screen for ALD and AUD. For AUD, they actually do a good job in most places, like an audit or even an audit C. It's a screening tool, it's not going to diagnose anything, but it can help to identify who is at high risk of an alcohol use disorder. In the liver disease part, what we want to identify probably is who is progressing to fibrosis, to significant fibrosis or advanced fibrosis. The easiest thing to do there is a FIB-4,
Hmm.
which only use, some of the liver function tests, so AST and ALT, plus platelets and your age, and it's going to tell you you are low risk, intermediate risk, or high risk. If you are intermediate or high risk, you need to get additional testing. But I think it's a good entry point. Many health system now has the FIB-4 calculation incorporated into their electronic medical records. So actually the physician doesn't need to do much more than just look the number and take action if that means referral or something else. I think that's what we can ask to our primary care physicians. But my second point is I will say patient awareness and patient empowerment, because if the patient is asking, that is probably going to start moving the needle, right? Saying, hey, I have liver disease in my family, or this and that, or I read that, if you are more than 50 and you have either heavy alcohol consumption or diabetes or obesity, I should get tested for this. I think that is what is going to move the needle. Unfortunately, many times in the medicine field, what has happened is sometimes priorities are actually by patient pressure. And if the patient starts saying, "Hey, what is my fit for?" then we are going to get some opportunities for early diagnosis. It's a long shot though, because I mean, we
Hmm.
will need to permeate to the general population and a more liver
Hmm.
awareness. But unfortunately, and I always say, unfortunately, the liver doesn't, you don't get pain because of the liver.
Hmm.
There is no nerves. So
Hmm.
it's not like the heart. I mean, if you have one of your arteries blocked, you are going to know and you are going to rush to the ER. But unfortunately, the liver, you don't have any symptoms. And even worse, like if you get yellow, many people will wait to see what
Yeah.
happened
Yeah.
and see if it goes away. Nobody
Mm.
run to the ER. They should be running to the ER. But I
Right.
think we have done not a great job as a liver doctors to really educate the general population in what
Hmm.
liver health means and what is liver fibrosis and what are the alarm signs and all those things.
Yeah. And I think some of this is going to improve too now that we do have more treatments coming online, right? If you build it, they will come, right? If there's if you're talking about, behavior modification, which was previously, with either weight loss or alcohol cessation, kind of, really the only ways that we had direct treatment of MASLD or ALD, now that we are seeing more and more, kind of medications, getting early approval like resmetirom or semaglutide, and then, just this slew of them coming down the pipeline, right? For all these indications, including primary indications for AUD for some of them and alcohol treatment. I do think that when there's a treatment that can, like a treatment in terms of a medication or something that can be offered, I do think that that also raises the awareness that people have about, oh, do I have this? Like, do I qualify for that? And so kind of a knock-on effect, I think, of having this maybe that what you do, as JP said, see more patients also being aware of their own risk factors and then raising it. And the extent to which we in the hepatology community, I think, can also simplify these diagnostic criteria, not having different cutoffs for the non-invasive tests for fibrosis for this disease or that liver disease or that disease, but trying to unify it so that a
Right.
primary care doctor can just say, okay, I just need to do a FIB4 or an ELF or whatever, NIT they choose, but the cutoffs are the same. Like they don't have to try to remember all this, complex stuff. I think that will make it easier to kind of do that early work of screening.
Um, and we have created a culture where let's find the magic bullet cure, right? The
Hmm.
mag silver bullet or the magic pill type of thing. And that's why
Hmm.
there's so much of reverence towards surgeons because there's this immediate intervention.
Yeah.
But ultimately, people have to do the work, right? And
Hmm.
and this is our uh, keeping to that comprehensive approach, even when we have new medications for this. And I do want to touch on addiction medicine. And we had Dr. Chana, who was involved with the protocol that had
Hmm.
0% relapse post-transplant. And so, what is the role of these addiction medicines as part of this sort of doing the work approach? On lifestyle, really going deep and understanding risk factors and behaviors.
I mean, my view is that they're very much adjunctive, right? They're not tested as monotherapy typically. They're tested as a medication that you take alongside doing behavioral therapy, and which is really like cognitive sort of relearning, how
Right.
to respond to various things in one's life without maybe reaching for a substance, whether that be alcohol or food or something else, right? So I kind of view the addiction medications, the relapse prevention medications, as kind of clearing the mental decks a little bit and allowing that, helping with craving to come down and to blunt that and to turn the volume down on that craving so that people's mental capacity, their cognitive capacity can be more available for that kind of ongoing work of, the therapy, regardless of what therapeutic modality they choose to do. But really the recovery from alcohol use disorders or even from, from overeating, et cetera, is very much about like relearning how to be in your environment in and how to respond to like annoyances or like major things, right, without turning to the food, the substance, the alcohol, so that's kind of how I view the addiction meds. A lot of times my patients only want to take an addiction med and like, okay, that's fine. Like we'll work on that. I give them the information, let them know they seem to work best when paired with behavior therapy. But by and large, that's kind of how I view them. Not a magic
So
bullet.
yeah, yeah, absolutely. And let's say that hepatologists are downstream, right,
Mhm,
of where things happen, right? Advanced disease, much more specialized care. And so upstream we get to the PCP, but we can go further upstream to the community. And that's what we try
mhm,
to do at the Fatty Liver Foundation, as well as Sober Livers. And we have patient journeys and we have the Wellness League, etc., going upstream to where the environment is. And a question was asked by Gabriella about the social determinants of health. And that's what
mhm.
we get to in communities, particularly at-risk communities. So what would you think is the alliance that we can create with hepatologists and for us who are based with the patient community in communities in order to try and effect this change and get to the
Mhm.
patients much earlier?
Well, I think it's just awesome that we have these patient organizations now for alcohol-related liver disease. I mean, we haven't had them, right? Like these are kind of it's
Right,
been it's been a challenge to do it. So I think it's incredible that we have it, I mean, in my mind, it's really as a hepatologist, I'm curious, like what does the patient community think would work, right? So like that's really where I'm just curious, like what do people think would work to where do people think as patients would be a great place to hear about liver disease? It's probably not the clinic always, right?
right,
Maybe it's somewhere else, maybe it's, at the grocery store or in church or in other community organizations or other communities that people frequent. I mean, I think that's like the really interesting and creative, process kind of out of curiosity. Like, I don't know. I'm not, I wait at present for people to come to me, but that's, there's a whole, like as the comment in the Q&A mentioned, there's a whole host of barriers that prevent people from coming
right.
into my clinic. And so from my perspective, it's really, about, I want to learn from the patient community, like why don't people go to alcohol treatment? What can we do to help them do that? What can we do to like that's just a really fruitful conversation in my mind. And mostly I would listen would be what I would.
Yeah, no, I completely agree. And I think this is a key point because, I mean, we can say from a scientific perspective what is the recommendation, but then putting that into real world is where you really start realizing that the social determinants of health
Mhm,
are so important.
mhm,
Um, one is we used to tell people, with NAFLD, you need to eat healthy Mediterranean diet and do exercise. And then, but the problem is, many people struggle with food insecurity. And
mhm.
then when you go to the grocery store, getting fast food is so much cheaper than getting, Mediterranean style
Yeah.
diet. Um, and then same with alcohol. I can tell you in some of the places, buying a bottle of alcohol is cheaper than the one of the fancy bottles of water. Like the access
Mhm.
then is a big problem. Or the other thing was I remember one of my patients that we were saying, well, you need to exercise and this and that. The problem is we're no place to exercise, no
Hmm.
single park in her neighborhood. Actually, there was no uh, pedestrian path in the entire neighborhood. I mean, it was
Right.
impossible to walk anywhere more than taking the car, going somewhere else,
Hmm.
and to work. So I think we really need to think, okay, for a specific community, for a specific, place, city, state, nation, what are the
Hmm.
things that will work? What are the things that it requires, extra work because this and that barrier? And I
Hmm.
think there is where community is really important. As you already mentioned, I think priorities for liver disease is early detection, early detection, early detection. How we do
Hmm.
that, I think my strongly feel is the solution is not telling the PCP you need to do this, you need to do that, and you need to do
Yeah.
that. It's not going to work. And it's not
Yeah.
because PCP cannot do it, it's because they already overwork. And
Right.
because it's adding more complexities. So I strongly believe that, patient communities, patient advocacy, patient societies is really need to help us to say, okay, well, this is the thing that we struggle. This is our priorities, our agenda. And then we try
Hmm.
to align agendas, how we can tackle these things from both
Hmm.
perspectives.
Yeah, the research needs to do this too. I mean, I think of research as kind of four links on a chain that goes from basic to translational to clinical, but then to healthcare delivery and health services research. And that's really what we're talking about here. We're talking about implementation, right? Okay, so we know that these things work. We know that we need to do these things. So the next step is what does work to deliver this to a given population? What does work to actually get these treatments that we've spent billions of dollars and decades developing, and then it hits a brick wall because we don't invest in health services research and implementation research to figure out what are the best pathways to go forward. So I think that's also an area that patient advocacy groups can get loud on. When we have Capitol Hill days for the AASLD, we almost never are talking about alcohol-related liver disease, right? Like that's not what we're there talking about for policy, but that needs to change so that we can get these types of things delivered to our patients and know what works from that healthcare delivery standpoint.
So I think you guys have summed it up perfectly, and we are just a couple of minutes over the hour. But if there's one message you'd like to give to every physician and every patient out there to remember about MetALD and ALD, what would that be?
You going
Who
to go
wants to go
first?
first?
Sure. I mean, I would say that there's hope that alcohol use is treatable. There's a lot of help and a lot of hope for this to get better.
Yeah, and I will say again, early detection is
Hmm.
we really need to try to find liver disease early in the process. So we don't need to talk about liver transplant.
Hmm.
And again, hope also goes for treatment.
Hmm.
I think Jess shares this feeling that in the past we were struggling to really offer treatment. And finally, there is no only one, there's multiple drugs that are in the
Hmm.
pipeline and they
Right.
seems to be effective. So hopefully we're able to reverse this process and then no one needs a transplant. So
Yeah.
yeah, I share the hope feeling.
That's a beautiful note to end with, and I want to thank you so much for your time and engaging on this. It feels like we're not dealing with this separately. It feels like it's
Hmm.
not just the nomenclature, but also our different specialties, our different civil society, medical, hopefully government comes on with this, etc. And we
Hmm.
start dealing this in a much more holistic way and meet patients and communities where they at. So thank you so much for joining us today, and we'll keep in touch.
All right. Thank you so much for having me.
Thanks for inviting us.
Thank you.
Take care.
Bye.
Bye.